This is an introduction to malpresentations and their management in pregnancy. We will start first by discussing normal labour and how the fetus descends through the pelvic cavity. So when we talk about labour, we talk about the powers, the passage and the passenger. For the purpose of this lecture, we'll be dwelling more on the passage and passenger. The bony pelvis has three principal planes. At its inlet, the transverse diameter is approximately 13 centimetres, while its antero-posterior diameter is 11 centimetres. The mid-cavity at ischial spines is roughly round with similar transverse and AP diameters. At the outlet, the AP diameter is 12.5 centimetres greater than the 11 centimetre transverse diameter. So, in the ideal situation, the baby or passenger enters the pelvis with head maximally flexed on the neck, vertex presentation. In this case, the presenting diameter from the anterior fontanelle to below the occiput is approximately 9.5 centimetres. Other cephalic presentations include deflexed brow and face presentations. The head enters the pelvis in the occipito-transverse or OT position. As the head descends further through the mid-cavity, it flexes and rotates through 90 degrees, so the head is facing the sacrum, and the occiput is anterior, the OA position. The head is then delivered by extension. The attached YouTube video demonstrates the head descent through the pelvis. Malpresentations such as transverse oblique, unstable or breech are often diagnosed antenatally. However, up to 30% of breeches present undiagnosed in labour. At other times, the malpresentation only occurs or becomes apparent in labour. This includes brow, face, OP or OT presentations. The incidence of breech presentation decreases from about 20% at 28 weeks gestation to 3% at term. Risk factors for breech delivery include preterm birth, previous breech delivery, uterine abnormalities, placenta previa, fetal abnormalities, polyhydramnios or oligohydramnios, high parity and multiple pregnancy. 70% of breeches are frank breeches, with hips flexed and legs extended so the buttocks are the presenting part. 15% are complete, with the legs flexed at the knees, so both buttocks and feet are presenting. And 15% are footling breeches. External cephalic version or ECV is sometimes performed to reduce the rate of breech presentation and therefore reduce the need for caesarean section or vaginal breech delivery. After ultrasound to confirm breech and to look for evidence of nuchal cord, a forward roll technique is employed. The breech is elevated from the pelvis and pushed to the side where the back is, while the head is pushed forward and the baby rolled. The success rate is quoted to be around 50%, with spontaneous reversion occurring in 3%. Success may be improved with the administration of uterine relaxants or tocolytics. Mothers considering ECV should be aware of the success rate. They should also be informed that 1 in 200 babies will become distressed, requiring immediate delivery. Following an attempt at ECV, a CTG should be performed for fetal well-being, and anti-D given if indicated by the woman's rhesus status. If there is a persistent breech diagnosed at term, there needs to follow a detailed discussion with the mother or parents as to their options for delivery. Following the term breech trial in 2000, there was a movement towards elective caesarean for delivery, as this was shown to be associated with reduced perinatal and early neonatal morbidity. However, a 2006 review of the term breech trial by Glazerman et al. Concluded that the original recommendations should be withdrawn, as most cases of neonatal morbidity and mortality in the vaginal breech group could not be attributed to the mode of birth. 2 years after the trial, there has been no difference in infant outcomes demonstrated between the two modes of birth, and we must remember that caesarean section increases maternal morbidity and mortality. With a skilled practitioner, a multiparous mother committed to a vaginal delivery, and a healthy, normal grown fetus in the frank position, the risk of an adverse outcome is low, provided there is no concurrent contraindications. It is important to remember the second stage is more stressful for a fetus in the breech position due to cord compression as the trunk descends through the pelvis. It is also important to remain cognizant of the increased morbidity and mortality associated with emergency caesarean section in advanced labour. Diagnosis of breech for the first time during labour is not an emergency and should not be an indication for emergency caesarean section. Risk factors for transverse, oblique or unstable lie are similar to those for breech. No action is required before term unless the woman presents in labour. If the lie is persistently unstable, the patient is admitted from 37 weeks, as there is a risk of cord prolapse if spontaneous labour occurs. If in this time spontaneous version occurs and persists for 48 hours, the patient can be discharged home to wait the onset of spontaneous labour. Otherwise, delivery is by planned caesarean section at term plus 10 to 14. This brings us to malpresentations more usually diagnosed during labour. The first indication possibly being failure to progress or prolonged second stage. With OP presentation, the occiput is palpated posteriorly near the sacrum. Labour is often longer and more painful. Many fetuses spontaneously rotate and deliver OA. However, if the OP position persists, instrumental delivery may be indicated. This can be achieved with Keelan's forceps or Von-2s. Persistent OT occurs when normal rotation is incomplete, usually as a result of poor powers, and is only considered significant after a prolonged active second stage. Rotation with traction is usually indicated and can be achieved with the Von-2s. Brow or face presentations are usually diagnosed following a vaginal exam indicated by failure of the head to descend. Brow presentation is rare, occurring in approximately 1 in 1,000 deliveries. Frontal sutures, anterior fontanelle, orbital ridges, eyes and root of the nose are palpable on VE. Delivery by caesarean section is usually indicated. Face presentation occurs when there is a complete extension of the head. The orbital ridges, nose, malar eminences, mentum, gum and mouth can be distinguished on VE. The presenting diameter is approximately 9.5 centimeters, allowing vaginal delivery by flexing over the perineum as long as the chin is anterior. If the chin is posterior, vaginal delivery is impossible, as delivery by extension would be required and the head is already maximally extended. Therefore, caesarean section is indicated. Cord prolapse is one of the obstetric emergencies and a complication of malpresentation. If cord prolapse or cord presentation is diagnosed on VE, call for help. Avoid handling the cord, as excessive handling may cause spasm. Instead, insert 2 fingers in the vagina and elevate the presenting part. Presenting part may also be elevated by catheterizing the patient and filling the bladder with warmed normal saline. The mother should be encouraged into the knee to chest position to further relieve pressure on the cord. Cord prolapse is indication for a Category 1 caesarean section. Delivery should occur within 30 minutes. Tocolytics such as terbutaline may be administered to abolish uterine contractions. I hope this lecture has improved your understanding of malpresentation and its ante and intrapartum management. Thank you for your attention.